Hello. How is everyone doing this morning? So, good morning and welcome to Harm Reduction equals Tenant Engagement. I hope we all could appreciate the expression of inner strength as much as I did this morning as the keynote speaker, Lori Yearwoods, presented. It was heartfelt, insightful, emotional. I felt like I was on the journey with her. I think that's what we all may share in common in this room. My name is Eric Senzon. I'm the Director of Client Services at Housing Works Bailey House. I've been serving the underserved communities for the past 20 years. It is my hope today that I can do this job justice in this important job as moderator. It's my first time to this Shinny conference. I know it comes on the 20th anniversary, and I welcome you all. We have two expert presenters today, one from Community Access, an organization that has a long-standing safe use supply distribution program that improves participants' well-being and truly meets individuals where they are at. And then we have an expert from the Center for Urban Community Services that has created harm reduction strategies for safe working for staff working with people experiencing homelessness in a range of situations. First up will be Emily Gerteis. I hope I pronounced that correct. She's the Director of Primary Care of the Janian Medical Care under the umbrella of Center for Urban Community Services, otherwise known as CUCS. Emily completed her family nursing practitioner medical training at Columbia University. She's been working with Jainian since 2014 and has been serving as Jainian's Director of Primary Care since August 2020. Emily is also an assistant professor at the Yale University School of Nursing. Please give us a warm welcome for our first presenter, Emily.
Thanks, Eric, and welcome, everyone. I talk really loud, so can you hear me in the back? Is that okay? Okay, so I don't have to get as close to the microphone. That's great. All right. Okay.
Emily, before you begin, I've forgotten to announce that we're going to do our presentations first and then leave the last 20 minutes or so for question and answers. Thank you.
Thanks. Yes, we love both Duysal and I both really appreciate the interaction with you all. So keep your questions, and we'll talk later. So I'm going to start our conversation by reviewing the connections between our physical health and substance use. So most of us in this room are really familiar with the language of substance use disorders, but we're going to review that briefly in regards to how it connects with harm reduction, talk a little bit about the intoxicating effects and withdrawal symptoms of common substances, and then review what are we preventing, right, with harm reduction techniques. When we're helping our clients utilize harm reduction, what are we preventing for them? So as Eric said, thank you, I'm the Director of the Primary Care Program at Jainian Medical Care. Jainian is under the umbrella of CUCS, and so when Jainian Primary Care was formed in 2012, it was coming in alongside this very long-standing psychiatric program called the Project for Psychiatric Outreach to the Homeless, or PPOH, which started in the mid-'80s just as a group of psychiatrists volunteering their time to do housing assessments for people who were homeless. And it all joined together in 2012. So today, Jainian is in over 25 programs, both supportive housing, shelters, safe havens. We have street medicine programs in 3 boroughs, and we have nursing services that kind of come in and are alongside all of those services. So we kind of run under with CUCS and Breaking Ground for most of our programs. So to frame our discussion today, I just wanted to bring it back to the clients, right? We're really here to be tools for our clients, right? Kind of a tool in their tool belt, so to speak. If we can know more about their experiences day to day, if we can know more details, right, then we can really help provide better services to them. So today when we're talking about all this, I just encourage you to think of a client or a few clients that you worry about. Maybe you haven't had a really direct conversation with them about their substance use, and maybe hopefully today you can learn a little something to bring it back to that client. So when we talk about harm reduction, right, we always want to avoid stigmatizing language. So we always start with person-first language, right? People who inject drugs is a very commonly used term now. You'll see it PWID in the literature. And I also want to frame substance use, right, as a very common thing, right? Most of us use substances on a daily basis. I needed my coffee this morning, right? So just as a reminder that the substance itself isn't necessarily a problem for your health. Of course, that varies. And of course, it varies, by substance and how much substance you take in. But something I like to tell my clients who use heroin is that heroin itself isn't the problem, right? It's everything around the heroin use that creates the problem for health, right? The sharing works, right? Sharing needles and not using clean injection technique, et cetera. And of course, Duysal is going to go over that later. So how do we diagnose substance use disorder, right? If everyone uses substances, then how do we diagnose it? Well, there's this constellation of symptoms, right, that we look at. Some of these, this is kind of from the DSM, right? So some of these that I want to highlight are what I see for my patients as a primary care provider, which are people spending a great deal of time, right, obtaining, using, recovering from the substance. Kind of their whole world revolves around it. You'll see people failing to fulfill, they're missing appointments, right? They're not going to work. They're not going to school, right? These things start to take over their lives. Obviously, there's other things here, including tolerance and withdrawal and cravings. But there's this constellation of symptoms that we utilize to diagnose substance use disorders. And then for the diagnostic language, there's more to this, obviously, in the DSM, but the severity depends on how many symptoms that somebody is endorsing themselves, right? I can diagnose them, but really it's the client that would tell me, I experience 2 or 3 of these things, so I have a mild cocaine use disorder, or this is really kind of explains my day-to-day life, and my substance use disorder is severe, right? And so I'm very transparent about that with my clients as well. Mm-hmm. So as a primary care provider, I love this idea of homeostasis, and I think it's a great thing to review here as it relates to substance use. So, as most of us have talked about with our clients or heard, that relapse is like a normal part of recovery. That there's these periods of relapse and recovery and abstinence. But homeostasis is this cool idea that the body is trying to balance itself out at all times, right? So for example, if you eat something really salty, your body is going to crave water. You're going to be really thirsty in order to balance out that sodium in your bloodstream and your tissues, right? And so substances, obviously it works differently, but it's kind of the same idea that if your body becomes accustomed to a substance being around every single day, like my cup of coffee, if all of a sudden that's just not there, then your body is going to say, where's the coffee, right? And act accordingly, right? I'm going to feel tired. I'm going to feel maybe moody, irritable. I might have a headache, right? And obviously that varies by substance, what withdrawal symptoms a person might have. But if you see that relapse is really just the body trying to regulate the brain and the other way around, right? And so this cravings, these feelings that you feel when you don't have that substance in your body, it's like just being thirsty. And so why wouldn't you quench that thirst? It's really not a willpower failure, right? It's this feeling like, I need to drink water. So I'm going to fix that feeling by drinking water, right? So let's move on into the common substances and their effects on the body. I hope this doesn't go too fast, but I think you guys are all you folks are very well-versed in these things, but we'll quickly review. So, list of opiates and opioids. The difference there is just opiates describes like the natural opiates that like heroin or morphine, and opioids are the synthetic versions. So that's like fentanyl. So how does it feel to be intoxicated on opiates? Immediate physical pain relief. You feel like maybe a distance from your body. Just this kind of sense of well-being and lightness. People's heart rate, breathing rate go down, blood pressure goes down. As someone working with someone that uses opiates, you might see that they have pinpoint pupils, like very small pupils, and they might complain of constipation symptoms a lot. Mm-hmm. Opiates are very constipating. Mm-hmm. But withdrawal is not life-threatening, luckily, unlike some other substances we'll be talking about. Some of the common withdrawal symptoms kind of look like the flu-like symptoms, right? Like nausea, vomiting, diarrhea. You might feel depressed, chills, sweating. The other hallmark is kind of like the runny eyes, runny nose situation that people have. And of course, I think this community has been inundated with, the tragedy of increased opiate overdoses. But just as kind of a reminder that the slower heart rate and breathing rate, right, when you take too much of an opiate, it slows down to dangerous lows, and that's called respiratory depression, and that's what kills you in an overdose. Moving along to benzos or benzodiazepines. All of these are legal prescribable substances that are very addictive. So benzos are great because they offer immediate anxiety relief, right? Immediately take away all of those feelings of panic. And benzos and alcohol act pretty similarly in the body, but benzos don't have any kind of like hangover symptoms. And so that is kind of on the pro side. And they're legal prescribable medications, so you'll see people seeking them, right, for me in clinic pretty often. Although you can buy them on the street, of course. Cons, it's because they're so wonderful at taking away that sense of panic, right? It's really hard to stop using them. It doesn't allow that person to work on the behavioral, in like therapy, for example, working on decreasing those feelings of anxiety naturally. So they don't have that sense that it will go away. And so as you feel panic and you don't have a benzo around, the panic increases, right? So they're very hard to stop using, and they can increase anxiety over time. Similar to alcohol here, withdrawal is potentially life-threatening, so it's important to remember that. A lot of times people are using benzos alongside other substances, and so, for example, the classic idea that like your methadone dose is like therapeutic and great, but that you'll take a Xanax, for example, and then both of those substances will feel more potent, and therefore you get a high from your methadone as well as the benzo, right? And so overdose risk increases when combining, and it's one of those that people combine a lot. Common withdrawal symptoms are feeling anxious, makes sense, not being able to sleep, being irritable, poor concentration. But again, when your body is used to a certain amount of benzo around at all times, if you immediately take that away, it can cause seizures that can lead to comas and death. So it's important to talk to clients about detoxing in like a hospital setting. So on to stimulants. It's kind of a menu of stimulants here, lots of different ones. But as you can see, other than cocaine and PCP, they're all pretty similar. Some of them are legal, some of them are not, but they all have that lovely word amphetamine in them, so that's how they work in the body. Even ecstasy is methyl-dioxymethamphetamine. So how does it feel to be intoxicated on stimulants? Really great, right? You feel really confident, you have more energy, you feel like everything makes sense, and of course, along with that, everything making sense can lead to feeling paranoid. Intensity of sounds and light can be a problem. Heart rate, blood pressure go up. I see that a lot in the primary care setting, and that'll be the sign, right? Are they using stimulants? Are they using opiates? The pupil might give you that key, right? That the pupils will be large in stimulant use. And because stimulants typically act kind of shorter in the body, right? They wear off pretty quickly. People are in these binge and crash cycles. So you'll have a certain amount of substance, you'll go through it in a binge pattern, and then have this like crash of like fatigue, depression, feeling irritable, and we've seen, I think a lot of us, that blunted kind of affect of like chronic users that when they're in that crash cycle. Honorable mention for our now legal cannabis, marijuana. So I want to mention here that it can be prescribed now, and maybe it'll be covered by Medicaid in the future, who knows, but right now it's not covered by any insurance. So therefore it's pretty inaccessible for our clients because of the expense. It does have really great harm reduction potential. I actually, for people who are actively injecting drugs and trying to cut down, where they're at that point where they're not ready to cut down because they still kind of need that high to get through the day, if you know those clients. I recommend using pot, not K2, pot, as an alternative because it is really great, right? It helps to relax you. It's an appetite stimulant for people who are chronic stimulant users, right? And people who are really thin. It's great for Parkinson's symptoms. It's great for chronic pain, especially for those people who are self-medicating for chronic pain. I do mention marijuana. But obviously with people who have psychotic symptoms, we really want to be cautious with that recommendation. And heavy smoking can damage the lungs, so long-term heavy smoking is not really advisable either, but or for young people. Definitely know young people, it can really harm their social development and cognitive development, so ways to avoid it. So now we've reviewed all of this, so what are we preventing, right, by using these harm reduction tools that Duysal is going to go over very concretely, which is awesome. The biggie, right, HIV, it's a blood-to-blood transmission. Also, we see it with sexual activity, but for this discussion, it's IV drug use for the most part. HIV dies pretty quickly outside of the body, so it's not commonly transmitted through like, inhalation drug use. If you get HIV, it's a lifelong disease and you're immunocompromised. Even if you don't get to the point of having an AIDS diagnosis, you are still at risk for opportunistic infections, like more at risk for pneumonia, more at risk for COVID, right? And negative effects of those illnesses. And obviously there's still the internal shame that people experience, external stigma, all those things are improving, I think, with lots of campaigns. I think you've seen them all in the subway. So hepatitis, we've got A, B, and C. It's a virus. Hepatitis is different versions of a virus that attack the liver. A and B are both preventable by vaccines, which is really important. And I frequently test for immunity to hepatitis A and B, and all of your clients should be also, and vaccinated if they are not immune. Hepatitis A, transmitted through the lovely fecal-oral route. So this is the one you see for people in close contact, unwashed hands. People, you can imagine people in encampments like using together, or close sexual partners or groups. and obviously you can get it through contaminated food or water. Hepatitis B is transmitted mostly through blood and sexual activity, although of course it can be transmitted through IV drug use, and it can become chronic, although most people clear it. Their immune system gets rid of it. And everyone in New York State, for the most part now, should be vaccinated at birth for this. Many people do need boosters. For example, I needed a booster. When I went to nursing school, I got tested and I needed a booster, so I frequently test for immunity. Hepatitis C is the other biggie. Hep C is transmitted the same as HIV, right, through blood, more so through blood than sexual activity, but blood-to-blood contact. Hep C can live outside the body for longer, so it is a risk with IV drug use. I'll put it down. Several hours later, somebody else will pick it up, and that Hep C is still there, unlike HIV, right, which you have to get it in the body pretty quickly to be infected. So only a third of people can naturally clear it. Most people get a chronic infection with Hep C. Luckily, it's curable, but without the treatments, Hep C leads to liver scarring and cirrhosis or liver cancer, right, hepatocellular carcinoma. The treatment is really easy, except, it can be difficult, right? It's one pill once a day for 8 weeks, for 12 weeks, depending. But it can be difficult for people who are still experiencing the chaos in their lives of homelessness or mental illness, or if they're still kind of in that everything around your life is using, right? It can be difficult to adhere to the treatment. Last but not least, infections. We've got skin infections, right? One is just cellulitis, which would be like a red area of infection. This is commonly happens for people who are, chronic pickers from stimulants, or possibly like skin popping. So if you're just injecting into the muscle or under the skin. Abscesses come more from IV drug use, or just the cellulitis getting really bad. Depends. But an abscess would look like a big lesion, like a zit. Sepsis, right? We all have this myriad of bacteria that live on our skin naturally, and so if you're not disinfecting the area before you inject drugs, you can inject bacteria into your bloodstream, and that can develop into sepsis, which is a blood infection. If that bacteria floats through your bloodstream and gets to your heart, this like low pressure area where your valves are opening and closing around your heart, they like to go there and start growing there, and that's called endocarditis, and it can have very serious heart effects for people. And it's endocarditis is commonly something that happens when you're an injection drug user. If you don't get that cellulitis or the abscess treated, it can turn into a bone infection, right? It'll go down into the bone. That's called osteomyelitis. Also, that can happen from sepsis. You can get osteomyelitis from a septic infection. And tetanus, also preventable, right, by a vaccine. It's a bacteria that likes to live on rusty metal, right? So all of these things are prevented by harm reduction, vaccination, preventative medicine, right? That's my passion, right? Preventing all of these things from happening. Of course, I treat them. But so I'm really excited to hear more from Duysal about the nitty-gritty of the harm reduction. These are some resources if you want. My favorite, if you haven't checked it out, is Mouse Party, which if you like the kind of biochemical things that happen in the brain with substances, it's a fun thing to check out. And that's it.
Congratulations.
Thank you, Emily. Next we have our expert is Duysal Karakus. Did I say that right?
That's a Karakus.
Karakus.
That's my fault. I didn't tell you.
Forgive me.
No,
No,
it's definitely my fault.
Duysal is the Senior Practice and Implementation Specialist at Community Access. She's been working within the agency's training department since 2012, providing trainings, technical assistance, and support around issues such as mental health and healing, harm reduction, trauma-informed services. She is passionate about using her clinical and human rights advocacy experience to address stigma, discrimination, and social justice-related issues in service provisions. Please welcome Duysal.
My selection of stuff here. Oh my God, being the perks of being short. Can you all hear me? Yes. Yay, with the mask too? Yes. Good, yes, perfect. Good morning, everyone. So today I am going to talk about Community Access's supply distribution program and also harm reduction strategies when it is related to this supply distribution program. And I am Duysal, and tiny little disclaimer, maybe not that little. As the title say, I'm going to talk about supplies. So that is also meaning that I am going to show some supplies that people use to use drugs. So I understand that it may activate some feelings, and if you feel like this is going to be like impacting you, a couple of things. There's not going to be all around, but there's going to be a section where I show you may lower your gaze, put your earphones, or you may choose to step out, then maybe come back. So that's what's going to happen for the section, because if I cannot show the supplies, it will be very ineffective to talk about it. The second very important thing, I'd like to thank all of you to be here today with us, sharing your time, sharing your energy, and another thank you for taking this topic very, very important seriously and being here with us. I'm really thankful and also grateful, and love sharing harm reduction all the day, all the time. So, a very brief information about Community Access. It's going to be like almost 50 years. Our agency is here. It started as very small, almost 50 years ago, with friends, family members coming together, renting and renovating apartments, and in the Lower East Side of New York. So it was clustered. And 50 years later, now we are a bigger agency. 3 boroughs that we primarily serve: Bronx, Manhattan, and Brooklyn. We do have other programs like our Howdy Heart Advocacy Center for peer training program, which is amazing. We have a peer-operated respite center, an art collective, a self-direction program, a health and wellness department that is so important and related to our topic today, supported education program, and also more. We have a pros program, some mobile teams, so it's a big agency now. And agency has been implementing harm reduction for the last 20 plus years. And it is one of our core values. Even though we are not a harm reduction center, in our housing program, we have been doing harm reduction for the last 20 plus years. And this is a slide that I wish we had all day to talk about harm reduction, all these specific topics. So it's going to be a little bit snapshots of each part. The first part is low threshold housing. So we do not ask people to, of course it wouldn't be harm reduction, to stop using drugs or also adhere to their treatment. So like housing first, and low threshold is one of the core values and what we do. So when people have that safe housing, then they can do whatever they want in their lives and address the issues that they are facing or reach the goals they want to reach. The second thing that we are doing as a harm reduction strategies are opiate overdose prevention program, which I'm going to refer as OOP. And I don't know, I'm hoping that some of you have your Narcans with you. And this is the most amazing kit I always carry with me. I am the program director. I'm the director for this program, the OOP. At this moment, we do have 17 dispensers at our agency, and then 14 different programs that we are dispensing Narcan to our participants, to staff, and also sometimes their visitors, family members. Needless to say, at this day and age, it's such a crucial practice, and I am very proud of this program. And we have been doing this program since 2017, when we are finally qualified to have the program, and it got bigger and bigger. The third thing, that's health justice and harm reduction. So when we talk about, when we are approaching to our participants, some of them have like really complicated health conditions, and then what we are trying to do is like taking these big social determinants of health and also approaching it from a perspective that, like, okay, there are some choices that we do in our lives, but there are some systemic issues. And then how can we also tackle that and talk it with people to improve their health? I'm going to talk very briefly about the food and food justice, and it is so important for our folks, and it is impacting their lives. And food is very dear to all of our lives. Like, we have our comfort food, we have our food that is related to our customs, traditions, our past, and some of them are amazing for us. Some of them cannot be that, like, it's not that good, maybe. It needs some adaptation. We may have some health concerns to pay attention. What we are trying to do is not forcing people to diet or exercise, like not coming from there, but like, okay, how can we keep what people want to enjoy and see if there are other options that they can also enjoy, bring into their lives, not losing the connection, and not always feeling like they have to give up what they really enjoy. The fourth one is our alternative approach to hearing voices and altered states. It could be an unusual belief system, also known as paranoias or delusion. Needless to say, when people are in altered states, sometimes the first reaction for some people will be calling 911, which can be very, very, very traumatizing and very harmful for folks. So we do have a training that we've been doing more than 20 years now. It's an experiential training, also created by people who are hearing voices. So this is an approach that, like, where we are trying to teach people more skills to engage in conversations when people are hear voices or when they have belief systems that can be risky or harmful, how they can feel more powerful and how they can increase their control over their voices, over their belief systems. And 911 is always last resort. So that is one thing that we are really doing. And similar approaches for psych drugs too. And drugs are drugs. You can get it from your doctor, you can get it from your dealer, and it's going to create some good, and it's going to create some not so good. And some of our folks are happy with the psych drugs they use, and some of them want to change the relationship. Either they want to come off or they want to lower. So when that happens, we are definitely not trying to convince people or mandate or coerce. And then again, use from a harm reduction perspective, what will be the less risky, less harmful way, and then they also feel like they have control, and then they don't have to go cold turkey and then experiencing all this withdrawal for whatever they are using. So that is a long-standing approach that we have. And we have plethora of safer sex supplies, from internal condoms, external condoms, dental dams, finger cuts, lubrications, like, so it's accessible to people and always trying to give sex-positive message. And Washington, this VHCP, Washington Ice Corner Project, and right now, Washington Ice Corner Project and New York Harm Reduction Educators, they merged, and they have the place that is on point. Our first, very, very, very first overdose prevention center at United States. New York is the first. That's amazing. And one good thing is we do have a long-standing relationship with Washington Ice Corner Project, and then they do have their pop-ups, and we do provide harm reduction services. And at the same time, sometimes people choose to engage with other providers too, or use both. They also bring holistic health approaches like massage therapy, sound therapy, acupressure, acupuncture. And also we have another syringe exchange program, and they can do that. So it is more like creating a sense of community, and when people come, people who use drugs, and then people who want to have the holistic therapy, they're engaging with each other. So less stigma, less marginalization. And now I am going to focus more on this supply distribution program. We have been distributing supplies since 2008. Again, with Washington Ice Corner Project, we started with collaborating with them. We have been paying people who are working at Washington Ice Corner Project who are also drug users, either former or currently, and they were creating supplies for us. And in time, when we increase more and more capacity to create our own supplies, we grow, and we grow. And so there is a mechanic to that. Like giving supplies is the mechanical part of harm reduction. It's important. However, if we don't embody the spirit, and if we give supplies, and then when we give out supplies, which I see sadly outside providers, that like when people are shamed, when people are schooled, when people are questioned, then yes, you are mechanically giving supplies, but that's not harm reduction, because in the spirit, where is the non-judgmental approach? Where is the compassion? Where is respecting people's self-determination? So the supply program also gives a message that we care about you. You matter. And your matter, your worth, your presence matter no matter what. And it doesn't condition that you use less or you stop using. If you are using, we are still here. If you change your mind and do something different, we are here. If you want to stop using, we are here. The most important thing is a human being. You deserve dignity, and we are here to provide services, support, and this unconditional professional love. So people feel like they can come and they can talk. So because when we talk about drug use, most of the time the conversation revolves around what are the harms, what are the bads. But when we give supplies, and then when we gain the trust that like, hey, what we say and what we do are in line, then people feel more comfortable talking about what they like about using drugs. I love smoking. I'm a cigarette smoker. I love it. Every single thing about it I love. I know it's a terrible thing to my body, considering my also family members and everything. But I would like to have the conversation with someone who doesn't school me and who actually asks me what kind of brand I like. Then I will talk about eventually what are the things that I don't like about it. So that's also one thing that we say for supply program, that like we are giving a message that you can talk about the good, what you like with us, and also not so good part too. And eventually our hope is this impacts people's well-being. And then they feel dignified, they feel cared for, and matter. Now, I am going to the section where I'm going to talk about the supplies, and in the next slide, I'm going to show some images. This is a long, long list. When we first started, we didn't have the fentanyl strip kits and the cigarette smoking kits, but it is, and also the meth use kits. So the safer smoking and safer injection kits, we have the full version, and then we have the half version with supplies that people use more regularly. They don't need maybe the entire things, but they need some portion of it. Abscess, I wish really we have more time to talk very detailedly about every single kit. So I'm going to choose two to talk more detailedly. The Abscess Care Kit is so important that like it is also very affordable. That when people who are injecting drugs, they can take these kits and take care of their injection sites and wounds while they're continuing to get like services from their providers. But they will also feel like they matter, their health matter, The safer sniffing and sniff test kit essentially the same material to sniff drugs. So it has like a sterile surface, cards, multiple color straws, because when you are with people, sometimes you share the materials, you share the supply. So we give different kind of straw pieces, so people know that this is their straw and they don't share, because sharing equipment is increasing the risk of infection. There's also saline water, which is like a pink ampoule, to clean the nostrils, and we give gums like BZKs, alcohol pads, all those things to sterilize any surfaces. I'm going to talk about fentanyl strip kits shortly. Safer cigarette smoking kit come from one of our harm reduction specialists. So, as I mentioned before, doing harm reduction, like providing supplies, definitely needs the spirit of harm reduction. And one of the important principles is harm reduction is peer-driven. So all the information, all this started with people who use drugs, people who are engaged in sex work, they care for each other, and they come up with these strategies. So people know what they are doing, and then we are trying to implement the same idea. And some of our workers in our harm reduction, either harm reduction specialist or another position, they use drugs formerly, and some of them are, I don't know if, I'm thinking maybe some of you have heard the name Dr. Carl Hart, who is a world-known scientist who is also very open about his drug use. And some of our workers are very Carl Hart-like, and they are open about their drug use. And the safer smoking kit came right after COVID, because we are working with individuals who are living in very dire resources. Some of them can afford their own cigarettes. Some of them cannot. And if you're a smoker, you know when you want to smoke and if there's no cigarette, you may pick a button from the ground. And that is definitely very risky. What we are trying to do with that, we have a cigarette, like a tip, but when people pick it up, then they can put this tip to the cigarette and they can smoke. So that is definitely come from people's expertise, and it's like, what is happening? What is the problem? And how can we resolve it? The safer self-injury kit is the only kit so far we have that has nothing to do with drug use, but this is a very trauma-informed approach. We are saying the same thing again. Hey, your health matters. And if people are engaging in any activity that may be cutting, that may be skin picking, burning, and then this tool has ointments, gels, bandages, sterile strips, so they can also take care of their wound. And they have that control too, and they have that power too, and then they can also talk to a provider if the wound needs more care. And the safer method is in preparation. So this is our new kit. I'm very excited. We receive our pipes, and it's going to be in practice very soon. Okay, here comes our interactive part. So, when you look at the image, some of them there's a gum, there's a BZK, a bandage, and a couple of other things. You may know, you may not know. Based on what you see, what do you think this kit is for?
Heroin.
Heroin is one guess.
Crack cocaine.
Yes, that is for smokable cocaine, crack cocaine. This is a kit, a safer smokable cocaine kit. So now let's go through a couple of items. Here on this is right, I always confuse my right and left. At the right, there is something in the Ziploc bag. You see? Oh, chore boy, here we go. Yes, that was the question. Chore boy. Once we are done with everything, I'm going to tell what is it for, how people can use it. How about the next thing? Right next to chore boy. The pipe. Thank you. There is the pipe. And how about right next to the pipe? It's a mouthpiece. Yep. And at the corner, in the context of, again, it's a chopstick, definitely. However, in the context of safer smoking kit, what will it be? The pusher. Yep.
But what does the Band-Aid have to do?
I'm gonna come. Thank you. So the chore boy acts as a filter, and then people. This is it, and then people place it in the pipe to use as a filter. This is a borosilicate pipe, strong, heat resistant. So because if people are using less quality pipes, there could be cracks, there could be chippings, and it can break very easily. But this borosilicate pipe is very strong. And the mouthpiece people choose because no matter what, if you heat this enough, it may burn your lips. And then some people choose to use mouthpiece. And the Band-Aid is for sometimes the cuts and everything. People wanted the Band-Aid with the kit for their cuts. And the chore boy, people use it as a pusher. And they place their filter, the chore boy, and then push, and place the smokable cocaine, and then they smoke. And the gum, like teeth grinding, to create saliva. So this is a full kit that we give out to people. How about the next one? Okay, any guesses about what this kit is used for? It could be for heroin. This is for injecting drugs. Yep. Depends on what people inject, but mostly people inject heroin in our community too. So how about let's start with the blue thingies. Yep. That is a sterile water. And how about at the right underneath the gauze? Yep, that is a cooker. And I'm going to explain once we are done. And at the top, what do we have? Yep, that's a tourniquet. Yeah. So, people use sterile injector water to dissolve the drug they use in a cooker, and the cotton in it acts as a filter. So people don't inject the hot drug to their veins. And the tourniquet is to find the vein easily. And alcohol pad and BZK to clean the surface. You use BZK after. You use alcohol pad before. And the bandages, again, people use for their any cuts. And then gloves. Sometimes people prefer it, sometimes they don't. Which I'm going to come towards the very end about what's happening with gloves. So these are some kits that we give and what they are for. So, and when we give out the kits, we also give out flyers. And that flyer explains how to use the kit and more harm reduction strategies. Some people who use drugs, they already know this information. They may not need it. Sometimes people want it. And then, as you can, maybe it is not that very clear, but it says thanks to Nairi. So, again, we are collaborating with people, and then they were gracious, and then they gave us their information. So we give credit to them because people who use drugs, they are the experts. They know what they are doing, and then we are just following their lead, and then making some adaptations and tweaks, but never co-opting the information. So giving the information and credit where it belongs. So we also add fentanyl flyers to most kits because at this moment, you may also know and heard that fentanyl is mixed with not only with opiates, with other kind of drugs too. So if people are using smokable cocaine, crack cocaine, it is also can be mixed with fentanyl. K2, some counterfeit pills, and Vicodin that they got from the street, and meth, benzos, people may not use opiates. However, if it is mixed with fentanyl, then they may definitely overdose. And this is the fentanyl test strip kit we give to our folks. This is a really good kit. One thing that is good about it, when you test your drug, and if it tests positive, then cool. You know that it is positive, and you can adjust the dose accordingly. However, the drugs, the fentanyl is not mixed homogeneously in the drug. So people can test a portion of it, and it may come as negative. That doesn't necessarily mean the entire batch is negative. Still, it is so important to test the drug. Absolutely, using with other people and using it slowly. Sometimes those strategies work with people, like it is just like slowly using, and then maybe they might want to snort before they inject and see the impact. But this fentanyl test strip kits, they are good, but they're not perfect, and that's an important information that we always want to give to people. False negative, it could be a false negative. So I am thinking at this moment, some questions are popping in your head. So I am hoping that like some of you may be able in a position that you can implement the program. But some of you might be in a position that like, I don't know how I can start a program, but I'm gonna give some tips that like even if you are a direct service worker, how to educate for it. That like what is needed, because this is so important, and you may start small. Starting small, maybe having 1 or 2 kits, and something is much, much, much better than nothing. So one thing that is really important for a program to work efficiently, to have a project manager. So I act as a project manager for our Safer Use Supply program. And one thing that project manager do, oversees the program and then create systems. Like that is, I'm going to talk detailedly about these bullet points: training, storage, ordering, kit making. This is actually, it's a very good activity to do together in a safely. Like right now I am doing it by myself because it is definitely not the safest way to bring people from different program and for long hours. So kit making as a group with participants or with workers, it's an amazing bonding activity, and then everybody feels like they're part of it. It also saves time. And I'm going to talk about documentation and distribution. And again, starting small is a good thing, because whatever you can afford, that is much, much better than not doing it at all. So this is the part I'm thinking some of you might have some questions. Okay, what about the money? How much this costs? Yeah, right? Absolutely. I will be in the same space. So these are some approximation. It may fluctuate, maybe a couple of cents, etc. So when we 4 years ago. 4 years ago, we changed our system to put all the kits that I showed a couple of slides ago in one box. It was a toolbox, literal toolbox, and then we send it to every program. And some programs are using it still. Some program needs bigger tool than a toolbox because they distribute more kits. So for all the kits except the fentanyl kits and the cigarette smoking kits, the cost of the entire program was around $1,500. And some of the materials that we bought 4 years ago, we are still using it. And we distribute good chunk. Some of them we have to replenish yearly. Needless to say, one of them is smokable cocaine pipes. So 4 years ago, what we bought is still not there. And some kits are very expensive. Like fentanyl strip kits, it's shamefully expensive. It's $1 for a kit. The entire kit makes around that much. But some kits are not that expensive. Like Abscess Care Kits are definitely more affordable. And then whatever we bought 4 years ago to create Abscess Care Kits, we're still using it. So it's just sustainable in ways. And it may be that like sometimes because of your program structure or the policies, etc., you may not be able to give the entire kit, but you can also provide some of the individual supplies. Chore boys are really good commodity. It's a good filter. It's not the best filter, but it's a good filter. And depending on how small or how big you are cutting the chore boy, bigger is better because people can, like every use you need to, it's the ideal is you need to change the filter. So we are trying to juggle the ideal and the cost and etc. We are somewhere in the middle, not the biggest chore boy, not the smallest chore boy. And then the gauzes, ointments, and cookers, like those are something that like they cost less. And then it could be an individual supply. It doesn't have to be the entire kit. So hopefully this is like if you are again a direct service worker and if you want to advocate, at the end I'm going to give my contact information. But this is something that is definitely you can be an advocate. And hopefully some of you are in a position of power that you can bring this program to your buildings and programs. So now the protocol part, the training. And again, we provide regular trainings about like what the kits are, what is in it, how can you use it, what does it do, etc. to people. And then we do regular harm reduction trainings in our agency so people have the principles. So we are maximizing options. We are respecting self-determination, peer-driven, non-judgmental, and hopefully we also celebrate any small or big change. So this at this moment we do have a capacity to provide online trainings, but it doesn't have to be like an online training. If you are in a position to do regular trainings about like how to use the supplies, what are they, how they are preventing harm, there is one thing that is so important. So because some people know that information, and some people need, like, you may not know every single drug, and you may not know how to use supplies for every single drug. That's okay. And documentation is an important part. We are a harm reduction agency. We are always trying to do what is best for the participants. We are also funded our funders, and we need to show our funders that by providing the supplies, our goal is to enhance engagement. Like these are there to engage with folks. So they can come and they don't have to hide their drug use, they don't have to feel like they have to lie, they don't have to feel like they are shameful. So this documentation is like shows that, hey, there is more engagement when we start giving supplies. And more quality engagement about multiple aspects of drugs. Like what is good about drugs? What is the relationship with the drug that the person has? How much control they feel like they have over the drug? And then what are some environments that they are using? There's so many areas that you can have a conversation. I think that is what I love about harm reduction, that it is like a fresh breath of air. That like, I do not have to have a conversation about only the drug itself. Use less. Can you use a different kind of drug? Can you stop? And if none of these work for folks, then I can talk about their motivation of use. Then I can talk about their relationship. Then I can talk about their past. And then I can talk about in what environment they are using. So if they are using in a space that is risky, then we can work on that. That is harm reduction. I'm not saying anybody to use less or to use less frequently or change the drug they use. What I'm trying to do is having that communication to identify the harms in either the drug itself or the person's motivation, their relationship, their past histories, their physiological, psychological aspects of drug use, or the environment that they are in. So all these things is a lot of areas to talk about, and as a worker, I feel like, you know what, the things that we can do together is not limited to only to drug itself. Because as Emily said, most of the time, the drug itself is not the real problem. There are other things that makes it more chaotic and complicated. And I am not like romanticizing. We are working with individuals that are really have very chaotic drug use in their lives. So there is some gist of the trade. The storage is important. It needs to be in a locked space, but accessible to staff. So unfortunately, unlike safer sex supplies, which is accessible, they are not locked. Because of the cost, we cannot, like we are still monitoring how much kits has given to programs, how many of them are distributed, who distributed the kit, and to whom. So when we are doing a reporting and documentation, and so far, we haven't had any issues with any auditors. Nobody reported anything. The only thing that auditors ask if we are training people for opiate overdose prevention, Narcan use. So definitely when the documents and everything are intact, that is a plus. And the documentation has two parts: the note, the engagement with the person, and also the inventory that we created that, okay, this program, the program had this many kits, and the staff name, the initials of the staff, initials of the person, the date. So everybody is monitoring like who's getting what, because sometimes people are in more need, and then they may want to use more supply, they may want to get more supply that then we can provide. So those are not so good conversations, but that happens. And the last part about distribution is before COVID, mostly people were coming. And then I mentioned that we have harm reduction specialists, but any staff can distribute the supplies as long as they are trained in our agency. So you do not have to be a harm reduction specialist. You can be a direct service worker, service coordinator, case manager, other kind of direct service worker. You can still distribute the supply. They were picking up. So COVID happened, and then we start shipping the materials. It is costly, but it is the safest way. And again, you do not have to do that. You can still do a pickup, like a central location to distribute the kits, to store the kits, to make the kits. People come, people can pick up. We always have an emergency plan. We have a protocol of like when the department is going and sending supplies, but sometimes life happens in the programs, and sometimes some people are they need one of the kits urgently, then we have emergency plans. And this is a team effort. Yes, our department works on it, harm reduction specialist works on it, and also our office services people like Jennifer, kudos, I know she's not here, Jennifer, Gabby. Without them, we would not be able to function this efficiently during COVID. They worked tirelessly to ship the supplies, and also like when we get some returns, also on that end, like, and then Christine from purchasing helped us to make sure that like orders are going smoothly, and Anna from our health and wellness department. Without them, without team effort, it wouldn't be this smooth. So I am so much grateful for all the departments. And another thing that I'm grateful for our customers. So today, none of them can be with us, but we do have one feedback that is encompassing that kids are helpful. And I am glad that I can come to staff without fear of judgment. This warms my heart. And whenever I hear stories that somebody gets a Narcan, not because they use opiates or drugs, but they feel like they know a neighbor and they may overdose and they want to jump. Sometimes they come to this event and then they say, actually I don't use drugs, but I want to make sure that I am here too, so people don't feel like marginalized, stigmatized, like people who doesn't use drugs come to these events too. So definitely those are the memories and feedback that whenever I had a bad day, to remind myself, hey, this is good. So the rest of the feedback is we have customers, clearly they are happy with the program, and then they have feedback to improve. Chore boy size. People want bigger chore boys, and we are trying to meet that feedback. People want more alcohol pads in the injection kits, and we start to add more alcohol pads to other kits as well. Cigarette holders are too small. I don't know, as a smoker, how did I miss that? Shame on me. But they fit, but it is a struggle. So we are going to change our cigarette holders, and people want less limits, because right now with COVID, we even kind of broaden our limits. It used to be 1 kit for 2 weeks. Now it is 1 kit for 1 week per person. And again, as I said before, the peer-driven nature of harm reduction is at the heart of our program too. So we got an inquiry from one of our participants from one of our programs that if agency would consider giving safer meth use supplies. We got the feedback, we got the request, we ask, and we didn't even have to do the strong advocacy. We ask, is it possible? Can we have money in the budget? Needless to say, med smoking pipes are very expensive. We got the okay. So now we are working on the med smoking supplies. And so I am grateful for everybody that I work with and their wisdom, and I learn a lot from them. Like 15, 20 years ago, I didn't have all this expertise, and thanks to them, like I'm here, I'm talking about it, I'm sharing my passion, I'm seeing people excited, want to do, and it's all because of their generosity and the trust that they had in us. So this is definitely possible now. And thank you so much again for your participation. I am very grateful.
Great job. Thank you both for these incredibly detailed presentations. I wanted to start off with a question. This is the Q&A section of our program today. And I wanted first to get an idea of how many folks come from agencies that already embrace harm reduction. Round of hands. Okay, looks like a good majority. Is there anyone from agencies that have other methodologies like abstinence? Anyone here? Yes, 1, 2. Okay. So I'm going to start by asking those who may not have been had the experience or participated with using harm reduction, if you have any questions for the panel. If not, then I open the floor to anyone who wants to offer up their opinion or questions about the program today. No questions? Well, I do have a few questions, if you don't mind. So for our panel. So,
I have one question.
Oh, yes, sir. If you wouldn't mind.
I'm a big mouth.
Okay, then if you wouldn't mind standing.
Yay, we love projecting.
I'm James Patterson from Wrecking Ground.
Hi, James.
Hello, everyone. My question is this here. I understand the kits and I understand the preventive measures in place, but isn't paraphernalia still a charge?
No.
Nope.
No?
Nope.
No.
That's good. But you can't hear me? My question was, isn't paraphernalia, a person having paraphernalia on them, if they were stopped, isn't that still an offense? Isn't that still a charge?
It is not illegal to have paraphernalia in New York State.
Especially the unused ones. It's just like there's no trace amount of anything here that like, and again, it is not, and that is not necessarily how things go. So, but there is an advocacy and there's a law behind people that they can advocate if something happens like that unlawfully. But none of our participants we ever heard about that so far, very recently with the paraphernalia. Yeah.
Definitely a big change for those of us, or for those of you that have been working for a long time, that it's a big change that it's not illegal. But obviously still police can engage clients and arrest them for that. Maybe to take them in to see if they have any warrants or whatever, right? But then they cannot actually be held on that. Yeah.
Hello, good morning.
Hi.
My name is Thomas Bristow. I'm a life skills manager at Homeward NYC. And I was just curious, with the harm reduction model, do we have numbers, statistics of clients who have utilized the harm reduction model and came off of drugs, stopped using drugs completely?
There's a very broad question. I am gonna refer back to overdose, overdose prevention sites. So when it first started in Canada, Insight, it was back in the day, like 2006ish, I think. I may be wrong. But it was like way controversial than here, like at this moment. And they're very heavily researched how it is impacting people's use. And then what they are seeing is, along with decrease in this infection rates, people's use change. Like if so many people get support if they decide to stop using drugs. And then they show that like this model, this open model of like, come here and safely use your drug. And if you need support with the counselors, with peers, we are here if you want to change the way you use drugs. And it was effective. That is definitely heavily researched for insight. And that I know for sure. That is, and mostly I am thinking that like if people want to be abstinent, harm reduction is just like not against it, and it isn't helpful. If you're asking about particular numbers, I don't know off the top of my head. But I don't know, Emily, do you?
No, I don't. I think it's a great question.
Yeah.
I think it also brings up the idea that I kind of neglected to expand upon before, which is that like we all use substances, or many of us do, right?
Yeah.
And that if we take the morality out of substance use, right? Like I don't judge her for being a cigarette smoker. She doesn't judge me for drinking alcohol. I'm not going to judge, my client for using heroin. If we take the morality away from it, then we're just left with, what are the dangers that you're experiencing, right? Associated with that. And whether it's legal or illegal, we've seen, alcohol is a very, very terrible drug.
Oh my God, that's the
legal.
most toxic drug. Like
Right?
this is definitely way toxic than heroin.
So bringing it back to that, yeah. Sorry, go ahead.
More toxic than cigarettes?
Yes, I think so. Yes, more alcohol deaths for alcohol, I think, than cigarettes. I think so.
Cigarettes might be coming next. Like cigarettes are very toxic drugs. They're so toxic. Definitely, but they are legal.
I think the question is, if you look at what the program she was referencing, I think in Vancouver. If you look up those programs, you might be able to get some statistics if you're needing some kind of like fodder for your program to start some of these programs. That would be a great place to start, is reading up on that. Yeah, thank you.
Thank you for your question. Emily, how about statistics on the number of lives saved?
You're asking me, number of lives saved?
Yeah. You don't have to
Anybody? I think I could speak to. I wish now that I was prepared with some of the studies that support harm reduction.
I think with the overdose consumption side, overdose prevention side in New York City, this is not recent, but like 2 weeks after they opened, they overturned hundreds of overdoses. Like many people, like hundreds of people overdosed there, and they didn't die, and some of them. They didn't even have to use Narcan. They use other strategies, so people can come from their overdoses very smoothly. So they don't have to go to a withdrawal, a terrible withdrawal. Like they are also like using Narcan, not like the first strategy. They are using other strategies, and so far we haven't heard any deaths from overdose consumption side for the weeks that we have.
And harm reduction really also it markedly decreases the rates at which HIV, hepatitis C is spread in communities. And so when you see rates of hepatitis C, for example, before implementation of like a citywide harm reduction program, you'll see a huge reduction. And hepatitis C kills, it still does. I had a patient die this year from liver cancer associated with hep C. I have a patient who got HIV as an older adult from injection drug use, right? Like just a year ago. So these are things that are still happening in our communities, and with harm reduction, we can prevent those lifelong and really impacting diseases. But there are specific statistics about that. I wish I had them.
Hi. Do you have a question for us?
Yes. Hi, good morning. My
Good
name
morning.
is Fallon Theodore. I'm with Breaking Ground. So my question is, how do you bridge harm reduction with permanent housing? Like these are not people who are now in street homelessness. They're not on the street. They're in their apartments behind closed doors. and they're using actively. So how do we bridge that so that we're not losing our tenants who are now coming from, this life with mental health, substance abuse, and then giving them this information so that they can safely use?
Can I take that one?
Sure.
All right, thank you. I think I started off this morning by establishing that I've been in the industry for 20 years, serving the underserved. I'm the director of 3 congregate facilities through Housing Works Bailey House. The long and short of it, the answer when you're working, you embrace harm reduction is longevity, understanding with compassion, being in it as a provider for the long haul, and being able to recognize that it's not going to be a smooth road for our clients. Housing Works Bailey House is not a low threshold alone agency that works in harm reduction. We are advocates and really propose expansion on harm reduction models. We take it very seriously. It's not so easy to observe on the daily, like what is it that we're doing?